very special global webinar with Professor Robin Carhart-Harris, who's on Mind Medicine Australia's advisory panel and a wonderful human being. So welcome, Robin, today to this webinar as well. It's gorgeous to have you here and to see you.
Yeah.
And we'd like to acknowledge all of the owners of the lands from which we come from, elders past, present, and we'd like to acknowledge the light keepers, the healers, the medicine men and women whose shoulders we stand on and who've brought us to this place today where we can be speaking about the transformational power of psychedelic-assisted therapies to heal humans from immense suffering. And we're very much looking forward to hearing Robin's talk in a couple of moments. We'd also love you to put up your hands if you're new to Mind Medicine Australia's webinar series. Do put up your hand if you're new here. Welcome. And welcome, well, quite a lot of new people, and welcome to those who are back to watch this webinar and part of our community already. Welcome to Mind Medicine Australia. We're going to show you just a few short slides so that you get a sense of what we're doing and where we're at in Australia with these therapies. Scott or Ilan, would you mind popping these slides on now? That'd be great. Thank you. And you can see we have people from all over the place. About over 500 people have registered for this webinar, but many of them will be watching the recording. So there's people from New Zealand, Australia, all over Australia, Massachusetts, from Colorado, California, Hobart, Perth, Sydney, Brisbane, Berkeley, Canada, Seattle. Yeah, and probably a lot of our European friends will watch the recording. There we go, Oregon. Welcome everybody to psychedelics and how they work in the brain. And who better to tell that than Professor Robin Carhart-Harris. Next slide, please, Alana. So just a note to all of you that we are focused on the clinical use of these medicines, and we don't promote the recreational use of these medicines. You should always discuss what you need with your healthcare provider, and this session is being recorded and will be shared on our YouTube channel. And you can go back and watch all of our previous global webinars on there as well. Next slide. So in Australia, we have a massive mental health epidemic, with 1 in 4 Australians with a mental illness currently, and expected 1 in 2 of us to suffer a mental illness in our lifetimes. 1 in 6 Australians are on antidepressants, including 1 in 4 older adults over the age of 55 and children as young as 4 years old being prescribed psychiatric medications. This comes at a massive cost to human life and suffering, and all the families and communities surrounding those people who are suffering, an enormous cost to society. Next slide, thank you. The elephant in the room, if we can go back to that elephant, please. Oh, where's the elephant gone? The elephant was there. There he is, or she. Hey, elephant. The elephant in the room is the lack of innovation in treatments for mental illness. And you can see the elephant there trying to get the attention of the bureaucrats, saying, come on, current treatments aren't working for the majority of patients. And if you look at the next slide, you can see that treatment outcomes remain inadequate. And there's been really no innovation in treatments for depression and post-traumatic stress disorder and a number of other mental health conditions and addictions for over 50 years. In the case of depression, only about 15% of sufferers experience remission from mainly antidepressants and or psychotherapy. Some show some response, but then relapse, and there's very significant side effects that occur with a range of antidepressants and difficult to withdraw. In the case of post-traumatic stress disorder, as few as 5% of patients go into remission from existing treatments. So more of the same is not going to solve the problem. Next slide. Mind Medicine Australia is a charity that was set up by myself and my husband, Peter Hunt, nearly 6 years ago to increase the treatment options available to doctors and their patients through the use of psychedelic-assisted therapies to treat a range of mental illnesses. Our focus is a whole-of-system approach, and we want to make sure that psilocybin, MDMA, and ketamine are part of the health system in a controlled way. For us, success means that these therapies become an integral part of our mental health system, that they achieve high remission rates, and currently those remission rates, and Robin will talk much more about this, seem to average around 60 to 80% across a range of trials and lead to substantial improvement in the mental health statistics that we're seeing around the world. Finally, as a charity, we're very passionate about these medicines being accessible and affordable to all Australians in need, no matter their location or their financial circumstances. Next slide. So medicinal psilocybin is primarily being used to treat depression at the moment, but I'm sure that Robin may speak about some of the other conditions that it's also being researched for, like obsessive compulsive disorder, fibromyalgia, and a range of addictions. The remarkable thing about these medicines is they only require 2 to 3 medicinal treatments in combination with a short course of psychotherapy over a period of about 16 weeks. So they're curative medicines. They're not just managing the condition. And they're considered to be very safe in medically controlled environments and non-addictive. Both medicines were granted breakthrough therapy designation, which is only granted to medicines that could be vastly superior to existing treatments to fast-track the approval process. Next slide. Thank you, Alana. So our focus at Mind Medicine Australia is on 4 key strategic pillars to build the ecosystem to ensure that these treatments can be accessible and available in Australia and affordable. So our first pillar is awareness and knowledge building, and that's what today is about in our global webinar series and lots of public events and presentations. So if you're out there in a workplace or community and you'd like a webinar about this rapidly emerging field, then we would be more than happy to come and present for you, or some of our psychiatrists, psychologists, and other practitioners can come and present to you, or our graduates from our certificate in psychedelic-assisted therapies. We also talk to the media a lot and various and diverse stakeholder groups, ranging from medical practitioners to politicians, construction industry, and other industries. We have one of the world's leading certificates in psychedelic-assisted therapies. In fact, David Nutt described our certificate in psychedelic-assisted therapies as the world's leading certificate in psychedelic-assisted therapies. And we probably have a number of our graduates on this call today. So far, over 500 psychiatrists, psychologists, GPs, physicians, nurses, social workers, and others have graduated from our training program, which features a world-leading faculty, which I'll show you in a moment. We also have a Fundamental of Psychedelic-Assisted Therapies course, which we're running in partnership with Drug Science UK. We also sponsor a number of trials and research around Australia, and we helped launch the Neuromedicines Discovery Centre at Monash University. We're focused on patient access, regulatory access gateways, which of course occurred through the recent rescheduling of MDMA and psilocybin, which was through our applications to Therapeutic Goods Administration. And I'll talk about that in one moment. And we have a patient support fund to support the upfront costs, up to 50% of them for patients who otherwise couldn't afford these treatments. Next slide. So these are some of our key achievements. We became the first nation in the world to reschedule MDMA and psilocybin in 2023. And since January this year, over 70 patients have been treated with MDMA or psilocybin under the supervision of psychiatrists and psychologists and their practitioner teams, which is extremely exciting. We also did launch our patient support fund this year. And here are some of our other exciting outcomes and the research we're supporting as well. Next slide, thank you. So here's some of the headlines that occurred when the rescheduling occurred, and there was over 200 media in some cases, front page headlines about this very historic moment of rescheduling last year. Next slide, thank you. Our certificate in psychedelic assisted therapies, and on November the 30th, in just 17 days, it's about 17 days, we will be closing our first intake for 2025. And for those of you that have done our training, you'll know that our training always sells out. And for those of you who are clinicians on this call, if you're a clinician, please wave your hand or tell us what profession you are in the chat box. And we'd love to welcome you to our certificate in psychedelic assisted therapies for either our February or is it July intake, Scott? Yep, July intakes for 2025. And you'll see the testimonials on our website are quite extraordinary. Many of the graduates describe this training as the best professional development they've ever done, not only in psychedelic assisted therapies, but it's given them therapeutic skills and other life-changing outcomes, which they wouldn't have achieved if they hadn't have done the training. Next slide, thank you. And this is the faculty, an extraordinary faculty, including Professor David Nutt, Dr. Geeta Vade, Dr. Lauren McDonald, Dr. David Arizzo and Bessel van der Kolk, Gabor Mate, and a whole range of other extraordinary practitioners. So we're very, very fortunate to have this faculty. We're grateful to them every single day. Next slide. Apply now, absolutely. Applications close on the 30th of November. Scott Edwards is there who manages the course, and he can answer any questions about our training in this webinar, or you can just email Scott. Scott, I'm going to ask you if you could put your email and links in the chat now so that people can email you directly as well. Next slide, please, Alan. And this is our Fundamentals of Psychedelic Assisted Therapies, our course with drug science. And you can see that's just started. In fact, it's nearly finishing its first intake, but we're, I think, accepting applications. Are we, Scott, yet for the next intake?
You can actually enroll for the self-paced version of the course, so to go through the recordings of it in the meantime, for those who are ready.
Wonderful. If you could put a link to that as well, Scott, I'd really appreciate that. Next slide. Thanks, Ilan. So lots of people say, well, how can you help? And you can, of course, help us. We're a charity and we're doing big things with, you know, a small team and a lot of voluntary support, and we need a lot of support. And so you can fundraise or donate either to our patient support fund or our general fund. I encourage you, if you're having an upcoming work lunch or some other event that maybe you fundraise for Mind Medicine Australia as your charity of choice, please do speak to your GPs and other therapists and encourage them to do our training, attend our events, read our incredible Learn section on our website, which has lots of incredible information about this field. And we have lots of downloadable documents you can learn about and learn from as well. Next slide. This is about our patient support fund, which I mentioned before, and I really encourage you to donate big or small amounts. They all help to support those in need who otherwise couldn't afford these treatments. And Scott or Alan, I'm going to ask you if you can please put a link to the patients that we've already supported. And you can see that we've already contributed $63,000 to support 7 patients to have these treatments, including some veterans and first responders. And Alan or Scott, if you can put a link to that document about the 7 patients who've already had treatments, that would be wonderful. Next slide, thank you. And other donations support training, research, development, events, and so on. Next slide. And yes, well, I'm presenting a workshop next Monday, Sound Healing, Loving Kindness and Connection workshop with the wonderful Dan Byrne. So we encourage you to come along and register for this event. Ilan, I'll ask you to put a link to this event so that people can register for next Monday. This will be very special. We've been doing this work also with our CPAT graduates and students, and people just love these sessions of coming together and connecting with one another and feeling the resonance and vibration that we can create of healing between us. Next slide. These are our upcoming webinars. So you can see Professor Alan Young is our next webinar in December. So register for that if you haven't already. And then you can see our extraordinary program for 2025 already emerging with Professor Nutt, Bill Richards, Heather Lee from the US, Jonathan Robinson, very interesting author on MDMA-assisted therapy, Jim Fadiman, who was always very popular. Next slide. Well, I think that might be it. Is there another slide? Let me see.
That's it.
No, that's it. That's it. Okay. Well, so now I am thrilled and honoured to introduce Professor Robin Carhart-Harris, who's a British psychopharmacologist. He's the Ralph Metzner Distinguished Professor in the Department of Neurology at the University of California in San Francisco. Previously, he founded and was head of the Centre for Psychedelic Research at Imperial College London, which is an organisation that we have a really deep partnership with, thanks to Robin and Professor David Nutt. And we're just eternally grateful to you, Robin, for your friendship and your support over these years. He's noted for his brain imaging studies on psychedelic and psychoactive drugs, such as LSD, psilocybin, MDMA, and DMT, and research into their therapeutic use in treating psychiatric disorders such as depression. In 2020, the Times named him one of the world's top 31 medical scientists. The following year, he was inducted in Time magazine's 100 Next list of 100 notable people poised to make history. Robin, wow, you're doing amazing things. Thank you.
Well,
big round of applause to you and welcome. And we're looking forward to your presentation. And folks, Robin will be taking questions. So please put your questions into the chat as Robin is presenting. We will be delighted to moderate those questions and Robin will be thrilled to answer them. Welcome, Robin.
Thank you. Thank you so much, Tanya. It's fantastic to be with you and to just see how impressive you guys are doing it. You're really doing it. It's so fantastic.
Thank you.
Setting the pace for everyone else. And I hope, others can catch up and follow your inspiration. It's fantastic to see.
Thank you.
So I'll be moving pretty swift through this talk, which is about psychedelics and how they work. I'll give you a definition to begin with. We'll start with a two-pronged definition, and that's intentional because I approach, in a sense, this space with a certain philosophy that treats each side of the coin with an equal weight, the psychology or the phenomenology with as much importance as the biology. And I think that's especially important when we work in the space of psychedelic therapy. So I'll address the pharmacology in terms of a definition of the classic psychedelics, the prototypical psychedelics, compounds like LSD, psilocybin, DMT, mescaline. And with these compounds, we know that they do work through a particular serotonin receptor, a particular receptor. It's the serotonin 2A receptor. It's heavily expressed in the cortex, that aspect of our brain that we have so much of. It's really what sets us apart as a species from other mammals. We have so much of this cortex, and especially so this high-level association cortex. And lo and behold, that's where the serotonin 2A receptors that psychedelics principally work through are most densely expressed. There's one anomaly to that rule, which is V1, the basic aspect of the visual system, where 2A is also highly expressed there. But we know that the 2A receptor is key because there's a strong affinity to potency relationship. Those psychedelics with the highest affinity are the most potent, and those with the lower affinity are the least potent, compounds like mescaline, for example. So that's how you can, in a sense, titrate dosage almost by the affinity for the 2A receptor. Not that we do that, but maybe we do it inadvertently, if you follow me. Now, we know that that receptor is key for another reason. If you block it with a so-called antagonist and then give a psychedelic, people won't trip. And more recently, it's been found that you can abort a trip through giving a blocker after the psychedelic, a kind of ejector seat, if you want. We also know that kind of sanity check here that the more 2A receptors occupied by escalating dosages of, in this case, psilocybin, the more intense the subjective effects. So pretty strong converging evidence for the importance of this receptor in the action of psychedelics. The phenomenology, that other side of the coin that's just important, I kind of have to race through this to cover the essentials. First of all, the etymology, the term itself, psychedelic, goes back to 1956. And this man, Humphrey Osmond, what does it mean? Beautifully poetic. It means soul, psyche, and revealing, to reveal the soul or to make the soul manifest or visible. So is that a legitimate term, I wonder? One way to go about that is to sample the phenomenology. And that's what we did here, first with the Delphi process, and then through an online survey where people dose-dependently rated their experiences with 3 different compounds. One, the classic psychedelic psilocybin, and the other one, MDMA, and the other one, ketamine. And what we found was that certain items preferentially loaded for one dimension that strongly matched the phenomenology of MDMA, items like I felt full of loving feelings, I felt full of love. Another factor loaded dose-dependently in line with what we know about ketamine. I felt like I was floating along in space. Motor control felt strangely impaired. And then another factor, the red one, loaded for the classic psychedelics. Items like I could see deeply into the human mind. And then if we went with a 4-dimension solution, there was a visual factor as well. So we could either go with a 3-factor solution that passes between the 3 drugs, or a 4-factor one that passes also within the classic psychedelics. One dimension that refers to psychological insight, psychedelic, psyche revealing, and another dimension that refers to the visual aspect of that experience. So complementary, but also somewhat distinct. This was an exercise in passing. I could be free and easy with psychedelic as an umbrella term covering a bunch of compounds. I can roll with that. That would be a kind of, generalization exercise, or a sort of lumping exercise, put it all in one bucket. But sometimes an argument can be made for more precision in our definitions. And if we want a precise definition of classic psychedelics or prototypical psychedelics, this is one that I'm giving you. So the classic psychedelics, especially promoting psychological insight and these visual experiences of a certain quality. So that's setting the scene for what drugs we're thinking about, the classic psychedelics. What's the latest clinical evidence for these compounds used in the context of psychedelic therapy? Well, there's a lot, and it's growing all the time. You can see there's certainly a lot of work in the space of depression with, as Tanya said, response rates averaging around 70%, the typical range 60 to 80%, so very good, better than conventional treatments, whether that's psychotherapy or SSRIs in depression. Response rates there tend to average around 50%. Even placebo will get you 40% response rates. What take-home messages should we take from this rich and growing evidence base? Well, one is that virtually all of the trials manipulate the context or set and setting in which the drug's given. The clue's in the name, psychedelic therapy. It's not just giving a drug, but giving a drug in a particular way. So we shouldn't gloss over that. That's where the evidence is. We should better test it in the sense of testing our assumptions that the responses to psychedelics critically depend on context or set and setting. That's a work in progress that personally I'm working on at UCSF. Really important problem. Another take-home message would be the rapid action, enduring response with few administrations of drug. So in a sense, compared to conventional pharmacotherapy, much less about drugs and more really about, I would say, the psychotherapeutic action of the intervention. Also the transdiagnostic action that quite a range, diverse range of psychiatric disorders, diverse in a sense, but maybe not so much in another, are showing signal with psychedelic therapy. And that's important. We're going to go there as we move on. So let's address causation, because really that's where it's at in this space. We need an intervention that has a substantive action that's more than just some kind of snake oil. I think many of us on this call will believe that psychedelic therapy does have that substantive action, but we still need to demonstrate it and convince the skeptics. And, that's one of the things that gets me out of bed in the morning. I think the evidence is really compelling here. Let's run through the psychological, some psychological models of causation. Here we see in this naturalistic data set, but I see it again and again in other data sets. You can see some of that summarized at the bottom, that emotional breakthrough, emotional release, emotional catharsis, strong emotional responses, behaviorally, physiologically, often looking like people crying, releasing strong emotion. That seems to be predictive of improvements in mental health outcomes, albeit in this model via psychological insight. I think in this model, this was scored the next day after the experience. So this is a strong predictive path towards improvements in mental health that we see. Sure, there are other components to consider, but this is the strongest path that we see in our data. Let's keep flowing. Therapeutic alliance, known to be a core common factor in the action of psychotherapy. And here, lo and behold, it's an important factor in psychedelic therapy in this particular data set in mediating or predicting response to psilocybin therapy for depression. So therapeutic alliance, predicting rapport on the morning of the session, which is essentially about trusting the people who are looking after you. Just even with just one or two items, we can see scores there predicting the emotional breakthrough experience, and then that experience, as we know from other studies and data, predicting the improvements in this case, depressive symptom severity. Another potential candidate causal action could be positive expectancy. That's what the skeptics often throw at this intervention, that maybe it's all some kind of placebo response. The best way to address that is to test it. And that's what we did in this double-blind RCT. So we tested ahead of time, measured ahead of time people's expectations for the two treatments in this double-blind randomized trial. One was escitalopram, Lexapro, conventional SSRI antidepressant, and the other one is psilocybin therapy. And we asked people, how much do you think your depression will improve by the end of the trial? Where the best extreme would be complete remission, completely free of depression, and the worst extreme would be no change in your depression. What we found was surprising at first and interesting. People's expectations for escitalopram were strongly predictive of response to escitalopram. Those with higher expectations do better across 5 of the 6 outcome measures. With psilocybin, we found no relationship, none at all. In fact, directionally, it was in the opposite direction to what we're used to. And spelling that out, those with higher expectations did worse, those with lower expectations did better. So according to these data, a compelling case cannot be made that positive expectancy is a causal factor driving response to psilocybin therapy for depression. So if it's not that, what is it? And that's where we're going. First of all, let me just run you through the trial very quickly, double-blind RCT. And just in the interest of time, I'll jump to the main outcome measures, the main efficacy outcome measures. This is the full picture that unfortunately readers couldn't easily see because it was pushed into the supplementary material against our wishes, but that's the way it went. And all of the outcome measures except one favored the psilocybin arm with greater than 95% confidence. So that's what you're looking at here with these green bars, their confidence intervals. Basically, if they're over one side of the dashed vertical line, it means that if we were to sample again, we would feel over 95% confident of finding the same result, a favoring of a particular condition. And because of the data, that condition would be the psilocybin arm. However, there was one anomaly. and it happened to be our pre-registered primary outcome measure, and it missed just. And that meant that what dominated the narrative of this paper was that there was no difference between psilocybin therapy and escitalopram. I think that was a shame, because I think it might be misleading. It looks to me that this could be a false negative in this trial. It is what it is. It maybe managed expectations and some of the hype around psychedelic therapy, but I think a fuller picture we could say, quite fairly, is supporting the promise of psilocybin therapy versus a gold standard first-line treatment for depression. So a lot of promise there. Zooming in on just 2 outcome measures, pretty emphatic in favoring psilocybin versus escitalopram, 60% remission with psilocybin versus 21% with escitalopram. On the BDI, HAM-D, 50% remission versus 10% with escitalopram. So whether it's patient-rated or clinician-rated, on these measures, pretty emphatically supporting psilocybin over escitalopram. The side effect profile by rate was pretty even across the 2 treatments, but in domain quite different. Yeah, sure, I'm cherry-picking one that so strongly supported psilocybin sexual functioning. Dysfunction there with the SSRI, as we're used to, and very low prevalence of that with psilocybin. Going into emotional processing, we showed people emotional faces of 3 different types: happy, fearful, neutral. We found that in this assay, it was most sensitive to the escitalopram, the Lexapro, and specifically the Lexapro blunted the brain's response to all of those emotional categories. Whereas with psilocybin, mostly it was no change. The only domain where we saw any change was in neutral faces, where there was an augmentation of brain responsivity. So quite a different brain reaction, in a sense, to emotion at the end of the trial with these 2 different treatments. One blunting emotional responsivity, and the other one, if anything, augmenting it. Here's our 6-month follow-up data, and 3 domains that I've highlighted where there was clear separation. Depressive symptoms didn't actually separate in favor of psilocybin, but things get so confounded out at 6 months, other treatments happen and so on, that it wasn't entirely surprising in hindsight. But 3 domains that did separate, you could summarize as speaking to improved quality of life or general functioning. One is work and social functioning. One is a sense of connectedness to oneself, emotions, body, social connectedness to others, and a sense of feeling more connected to nature and a sense of purpose in life. So multifaceted connectedness, favoring psilocybin out at 6 months, and a sense of meaning in life, also favoring psilocybin out at 6 months. So these are outcomes, these are facets of being in the world that matter to people. And so to see them separate in favor of psilocybin versus that conventional treatment was pretty interesting. Here's an anorexia trial recently completed, currently being written up, led by these heroes, supported by the 2 heroes at the top there. And we saw 50% of the sample within the zone for being free of anorexia at 3 months, pretty promising. And so diving under the hood, in terms of causation, we did see that those with the higher psychological insight scores were those who showed the most improvement at the end of the trial. So suggesting that the psilocybin, and this was psychological insight in relation to the high-dose psilocybin sessions, suggesting that the psilocybin's doing what we're used to, and that may well be driving at least a good chunk of the response. Fibromyalgia syndrome, chronic generalized pain, zooming into the findings. Let me just tell you that quality of life very much favored psilocybin, big improvement in quality of life 1 month after psilocybin. 1 month after placebo in this fixed order within subjects controlled study. So people being their own controls, getting placebo first, then getting psilocybin 1 month later. Quality of life separated. You're not looking at those data here. I'm just telling you about them. Separated between the 2 treatments very robustly, strongly statistically significant. So that was good to see. And then in terms of mechanisms, this was a pretty mechanistic study. The patients actually wore EEG caps during the dosing sessions, done with a good amount of sort of grace and consideration, I would say, and yielding this fantastic data where the bigger the brain effect, and I'll explain what that is in a moment, the bigger the psychological insight, which, as I've already said, it seems to be a core causal vehicle driving response to psychedelic therapy. So what is that brain effect? You might have read it on the slide, you might know about it already. I call it the entropic brain effect. It is the principle that if you measure brain activity across time, the more unpredictable that activity, the richness, the state of conscious experience that someone's having. So psychedelics dial it up very reliably, very dose dependently. Other interventions that are psychedelic-like in their effects that can alter consciousness also are associated with an increase in the entropy of spontaneous brain activity. If you track someone with a disorder of consciousness, say coma, who's one of the lucky few that emerges out of that, then brain entropy will track with their emergence from that disorder of consciousness. We can look at the other side of things, states and interventions that are associated with a reduction of conscious level, whether it's being knocked out with an anesthetic or looking in disorders of consciousness like coma, looking in deep sleep, in aging, mild cognitive impairment. All of these states are associated with lower brain entropy. So super reliable principle for describing states of consciousness along even a singular dimension. But recently we're finding something that's even more exciting, and I'm taking you there now. So this is a healthy volunteer study. We called it the Insight study, Insight 1. People are given a placebo first. They've never had a psychedelic in their life, no psychedelic whatsoever. They're given a placebo dose of psilocybin first. We look in the brain a month later. We give them 25 milligrams psilocybin and look in the brain a month after that. And we also record EEG during the session. That's what I'm going to show you. We see the entropic brain effect. It peaks at peak intensity and drops down as people come down. But what we found, which is really cool, is that the bigger the entropic brain effect, the bigger the psychological insight. I mentioned that in the context of fibromyalgia syndrome. But we're seeing it here in healthies, and we're actually seeing that the bigger the entropic brain effect at the 3 post-dose time points that we measured, all of those time points, the bigger the entropic brain effect, the bigger the improvements in mental health 1 month later. So a change in the brain as early as 60 minutes is predicting by how much you'll improve in your mental health 1 month later. Pretty amazing if it holds as a so-called predictive biomarker of the action of psilocybin. A snow globe analogy, people like that. It's over a decade old now, but I first introduced it in an interview where asked how psychedelics might work in addiction. I said, well, it's like shaking a snow globe. You get people out of their ruts. And anyway, people like the analogy, and it's stuck, and I still think it's valid as far as analogies and metaphors can go. The entropic brain effect is best seen through the high temporal resolution of EEG, where the activity becomes more complex or diverse or entropic across time in the temporal domain, more going on. With fMRI, we can't see temporal activity with such a high resolution, but we can see spatial activity with a high resolution. And there we see entropy in the spatial domain. What does that mean? Well, patterns become finer grained. The larger coarse grained patterns break down, and the brain favors finer grained patterns. That's been shown with a few different metrics. So these days, I'm inclined to say that, looking under the hood of the entropic brain principle, we might actually see that brain activity is becoming faster in terms of oscillations, faster activity, and also finer grained. So in a sense, yeah, faster and finer, it sort of works, I think. And the psychological flip of that brain effect being the richer conscious experience, more going on, in a sense, more going on in the brain, more going on in experience, that translating into psychological insight, and that in time translating into improvements in well-being. If shaking a snow globe worked for the acute state, the trip itself, then a fresh coating of snow can work for the subacute or post-acute change, a description of the transformation, like a reset or a recalibration, getting out of those ruts and now having a freer space to move around in. Empirical evidence supporting that, drops in modularity across studies, 2 different depression trials, and now a third in that healthy volunteer study, bigger drops in modularity, which is like an increase in global functional connectivity or flexibility, let's say, or crosstalk between systems. The bigger that effect, the better the improvements in well-being. So it's an interesting biomarker, another one. The REBUS model, taking inspiration from predictive processing, it says that we experience the world through our predictive models. That's the predictive processing model. And what psychedelics do is that they dial down the influence or the weightiness of those predictive models. What does that mean on a more accessible level? Our assumptions about what's what break down. We're less sure about who we are and what's going on. That's a description of the trip itself, but it might also be a way to understand how a trip can be useful therapeutically, perhaps in psychopathology across the board, transdiagnostically. Our internal models become too weighty, maybe for defensive reasons. We entrench, whether that's negative thinking about ourselves and the world in depression, or the habits that might play out in OCD or eating disorders or addiction disorders, or habits of mind, cue-specific habits in a sense in anxiety disorders and functional neurological disorders where internal models are starting to dominate things too much. So if that's the common problem, I call it canalization, borrowing a construct from evolutionary science, which means a resistance to change. If that's the common problem, then what's the solution? Well, in evolutionary science, the direct inverse of canalization, what is it? It's plasticity. Plasticity, which means the ability to change, to be sensitive to the environmental milieu, to be malleable. It's the mirror opposite of canalization. Canalization is the problem. Plasticity as a good chunk of the solution. It's the opportunity, if you want. It's not all of it, though. Our assumptions are that this is a combination treatment. It's not just a drug. It's how the drug's given. So the assumption is that you induce changeability, malleability, sensitivity to context, and you exploit that opportunity by caring for people in a beautiful, open, compassionate way. And that's the magic sauce that we think gets people better. We can measure the REBUS effect very directly by asking people to rate the confidence that they feel in their beliefs. When we do that and we look at that confidence under the drug, we see generally a dip in confidence. That would be the REBUS effect. But when we look a month later, we see that healthy beliefs, such as positive self-beliefs, I'm loved, for example, they stay, like they were at baseline, or maybe even spring up, maybe even improve. Whereas negative beliefs, hinting at pathology, remember this was a healthy volunteer sample, but we're all human beings, we all have, complexes and so on. So those negative self-beliefs, it was interesting that those selectively dropped, continued to go down 1 month post-treatment when there was no change after placebo. The entropic brain effect actually predicted that or correlated with that. It correlated with the drop in confidence acutely in negative self-beliefs, and also predicted the continued drop out at 1 month. Pretty amazing if that holds. Putting things in a clinical context, just to finish, What about maladaptive? I put that in inverted commas because in a sense, these beliefs are defense mechanisms, so they're kind of adaptive. They're adaptive, yet they're the problem in a sense that we want to resolve if indeed people do want to be free of their symptoms, which isn't always a given. But we can measure this with this measure by asking people to share with us some beliefs at the core of their pathology. We did this in the fibro study, asking about negative beliefs about their pain or their bodies. Here's an example: my pain is deserved. We see the confidence in those beliefs, or the precision weighting, the weightiness of those beliefs, not changing with placebo or 1 month after placebo, only changing with the big dose of psilocybin and staying down 1 month later. Let's move into the anorexia domain. Egosyntonic beliefs, beliefs about how the anorexia is sort of wanted or serves the individual, wanted in inverted commas. Being thin makes me more valuable. There was a lot of references to a sense of control. The anorexia gives me a sense of control. So anyway, these beliefs, they don't change with placebo. It's only with the first big dose of psilocybin that they drop, and then they stay down. So this is a cool measure. We can share it if people are interested. It may well, we think, get to the core of what psychedelic therapy does, selectively targeting these entrenched ways of being in the world that are at the core of psychopathology. Thank you very much for this opportunity to talk to you and share, and I look forward to answering your questions.
Thank you so much, Robin. That was brilliant. And there's a lot of questions here. So I'm going to just start off with some of the first ones. So maybe there's quite a lot of questions, so we might do quick questions, quick answers, so that we can get through as many as possible. Scott, I will ask you once I've pulled up some of the questions if there's any others to suggest if they don't overlap some of the others. Well, firstly, you mentioned that what gets you out of bed each day, is convincing the skeptics. And I'm wondering if it's getting a lot easier to convince the skeptics now.
Maybe actually. Yeah, it depends on the audience. They're still there, but I would say, and it's good that they're there, and I really mean that. It's healthy. But we've got answers, we do. And so that's reassuring that sure, there are limitations, there's risks to everything, but we really do have answers over things like that tired, in my view, argument that this is a placebo mechanism. It's just not compelling. We have, I think, pretty compelling answers to that, pointed critique.
No, that's excellent. So there's a question here. Could you mention the brain hemispheric effects of psychedelics? E.g., question is, does one hemisphere get affected more?
Yeah, it's a great question. Often comes up, and historically I used to kind of poo-poo it because I wasn't a big fan of emphasizing hemispheric differences in function. I sort of felt that was sort of overplayed a little bit, a sort of pop neuroscience way of thinking of the brain. But there is something to it. And actually, in a data sharing project, sharing fMRI data across teams, across sites, we have seen some suggestions of an increase in interhemispheric communication under psychedelics. That's something that we'd seen in our own data historically. It's just, when you start seeing it across teams, you start to pay a little bit more attention. So I'm starting to walk back some of my own skepticism there about, hemispheric explanations for the action of psychedelics. It could and may well be part of the picture.
Thanks so much, Robin. Question here, what roles, oh, no, well, actually, no, Scott's already answered that one. Can Robin comment about whether he thinks there is an optimal window in which to do EMDR in the integration period, e.g., in the week following medicine day, maybe?
Well, that's pretty specific, and I don't know enough to give you an really informed answer. And I would just say, I guess going by, the window where we see the best improvements and people seem to be the most plastic because we don't yet know when they're the most plastic. Yeah, maybe the next day's too early, but at 1 week, yeah, that makes some sense. And, whether it's EMDR or some other psychotherapeutic intervention, making the most of that, hot period of plasticity, makes a lot of
Yeah,
sense. So
like people are
better
suggesting
understanding.
meditation, breath work, other
Yeah,
modalities. Well,
yeah. I think
yeah.
1 week's a good heuristic. Yeah, go slow afterwards. Not, no fast changes really. Yeah.
Thanks for that one. Robin, thanks for the talk today. I've been working with Ruben Laconin, looking at insights, false insights, and harm reduction in Pat. Can you comment on the idea of epistemic hygiene and careful holding of meaning-making spaces?
I'll give it a shot. Yeah, I mean, it's sort of related to that comment of go slow after the experience, that sure, psychedelics seem to promote psychological insight. People seem pretty emphatic about the realizations that they have when in the company of someone under the influence. They seem to be, for the most part, valid. They certainly seem to be often transformative in a positive way. Rarely do they seem delusional. But red is stopping short of being absolutist about this. So I do think it's possible that people can have false insights under psychedelics, and that it's something to watch. So in terms of hygiene, it would be careful not to be too absolutist about reports of insight, thinking that whatever people are describing in terms of their insight, that it's absolutely true. Hold it lightly. But for the most part, I think the insights are generally valid. They're often more of a emotional, visceral nature rather than an intellectual nature. And I think because of that, they carry weight and often carry people along in a positive way. So I think it's a good thing to bring into the discussion, but be careful of overweighting that one, is what I would say.
No, thanks for that. And just on that point, I mean, given the sort of insights and emotions that people do experience on the medicines, you were talking about brain hemispheres before, and I've heard a lot of people say that they feel much more in tune with the right side of their brain, their creativity and curiosity and so on. Would you agree with that?
Well, I doubt they know. Sorry, that was a cheeky thing to say, but they're putting a brain inference on a feeling.
Yeah,
So they just don't need to bring the brain into it. They could just say, I feel more in tune with my creativity. You
yeah,
know, you don't need to make it real by bringing in, or more real, or seemingly more real by bringing
yeah.
in the brain. It's my point. Yeah.
Scotty, can you just have a look at the next lot of questions, because I'm just having trouble seeing both screens at once at the minute. Just you'll need to unmute yourself.
Sorry. You can hear me now?
Yes,
Yeah, I can grab a couple of them here.
yes, thank you.
One question that's been put in is about psilocybin versus psilocin. In the current research programs, is psilocin also present alongside psilocybin? As the body metabolizes into psilocin, why not administer this instead?
Yeah, the simple answer, I could keep this one brief, is that psilocine's less stable. So that's why people have worked with psilocybin. It's just a stability thing. Psilocybin quickly becomes psilocin, and it's psilocin that's doing all the most, we think, of the action through the serotonin system. So we could use psilocin, it's just less stable.
Great, thank you.
And I've got a question here for you. Is there similar brain activity with people experiencing psychosis and those who have used psychedelics?
It sort of depends. A stamped in psychosis like schizophrenia with lots of delusions is quite a different thing to someone tripping on a classic psychedelic. So that comparison's been a little bit overstated. There are some similarities, but I think the overlap's more similar, and sure, I'm talking about the phenomenology, in sort of early or incipient psychoses, so before the conversion, where the self feels fragmented and the world feels a bit strange. That's where the overlap is stronger. And in terms of brain similarities, psychosis is a dopaminergic thing, and classic psychedelic states really aren't. Some people have argued that they are, but it's not compelling. You block psychotic symptoms, positive psychotic symptoms, with dopamine blockers very effectively. You block the aberrant salience. But when people are given haloperidol, a dopamine blocker, on top of a psychedelic trip, it hasn't really done much. It hasn't aborted the trip. So they're quite distinct, I think it's fair to say.
Scotty, you've got another question there. I've got a bunch here too.
Yeah, for sure. Another one here is a request for what sort of data do we have for longer term mental health outcomes with psychedelic assisted therapy?
Well, I showed the 6-month data. That's longer term, and I did emphasize the 3 domains that especially favored psilocybin, significantly favored psilocybin: meaning in life, connectedness, and so on. So yeah, it's there's that. Hopefully that's helpful.
No, that's great. There's a question here. Oh, always questions on this, but do you want to just speak to whether it's still necessary to taper off existing medications and that process briefly?
Yeah, I just say it's debated, and I don't think anyone really has the answer yet, despite what they might claim. I'm not going to claim I have the answer. We did an analysis that suggested it made a difference, meaning the longer you're off, the better. Even a 2-week tapering wasn't long enough, it seemed, maybe, to sort of recalibrate the brain and make people, nicely sensitive to psilocybin therapy. Others claim that people can stay on their meds, and sure, the trip might be attenuated a bit, but they still show a robust therapeutic response. That's interesting. It's interesting, and that's why I say I don't feel I have the answer yet, and it's debated, and we need more work there. I strongly suspect, that being on an SSRI and even coming off one leaves a downregulation of the serotonin system, meaning that you trip less hard, especially if you stay on your meds and if that washout period isn't long enough.
Yeah.
But whether that translates into an attenuated therapeutic response, I don't know. It would sort of fit a principle that the bigger the trip, at least in a certain domain of experience, the better the response. So I would suspect actually that it probably does take some of the edge even off the therapeutic response.
No, thank you. And just to that point then, what are your thoughts on the idea of removing the psychedelic phenomenology, e.g. the trip, etc., and still achieving any therapeutic outcomes that people have been speaking about?
I'm not a fan. I think it's part wishful thinking, part misunderstanding of the model, and part even sort of financial considerations around, the commercial viability, that not everyone's going to want a trip, and can we not get the good stuff without the scary psychedelic stuff? And that's why I think it's kind of, it's a little bit sort of ill-considered in my view, and a bit wishful thinking, and I just don't think it's compelling. Yeah.
Thank you for that. And then there's a question here: is phenomenology derived from spirituality, and has this evolved?
That's a curious question. The quick answer is no, but phenomenology is very basic. It's subjective experience. Spirituality, sorry, would depend on your definition of spirituality. But I don't think so. I wonder if that's coming from a philosophical position of idealism, like consciousness is fundamental. If so, it's a very interesting model, but I don't know how, sorry, how evidence-based it is. Yeah.
Thanks for that one. And this one is, are you basically saying that you can create negative plasticity and actually create negative pathways in the brain when exposed to negative thinking affirmations, and so during and after a psychedelic treatment.
Possibly. I mean, what's negative plasticity? I mean, plasticity that then goes in a negative direction. So, for example, mental health gets worse because of the plasticity that happened. You know, there is a type of plasticity called Hebbian plasticity, which a lot of people think is, in a sense, the main or even the only plasticity. Cells that fire together, wire together is the sort of buzz phrase that we use for that. It's associative learning in a particular direction. I don't think psychedelics necessarily promote that. That doesn't sound like healthy plasticity to me. That feels like the kind of process that leads actually to canalization and an entrenchment. It's Hebbian mechanisms that stamp in an addiction disorder, for example. So I think the plasticity that psychedelics promote is very basic, it's very general, and it's somewhat, you know, we can be agnostic about whether it's intrinsically healing. It might be, on average, it might trend in that direction, that recalibration, that reset effect, but it very much depends what you then do with that opportunity. So it's only negative in terms of what you could do with that opportunity.
Right, thanks for that. There's also often we get these questions. So there's sometimes confusion around the understanding of the difference between a microdose and a medical dose. And I wonder if you might speak to that, because we get this question very often, and people often think that a microdose is similar, which of course it's not. So yes.
Yeah, microdose is a classic sort of Fadiman definition would be a threshold perceptible dose, meaning really just below threshold. So you shouldn't notice its psychoactivity. At least you shouldn't notice the psychedelic phenomenology. And yet somehow it's working like a kind of mind and brain lubricant to lift people's mood and improve their creativity. That's the model. Whereas, you know, the doses that we use in psychedelic therapy are typically much higher. You're meant to feel them. In fact, you're meant to feel them pretty intensely. We give pretty high doses because of that, because it does seem that the quality of the experience that people have under the influence is a strong mediator of therapeutic response. So, you know, we want them to have those big experiences. Microdosing, fascinating model, just a little, you know, mixed in terms of the evidence base for it at the moment.
Scotty, have you got another couple of questions you quickly want to ask?
Yeah, sure. Here's an interesting one about what do you think are the long-term effects of psychedelic use? For example, is it possible that the brain can be moved towards like increased openness and sensitivity?
I suspect so. You know, that fresh coating of snow is trying to say that, really. You have a global system now, so the whole of the brain and its functioning, and the whole of the mind and its functioning, and it's recalibrated. It's less entrenched in habits. And so, and particularly those habits that define, you know, psychopathology, those unhealthy habits. So that would translate into, you know, a global state of being that is more flexible, that's more open, that's less entrenched and constrained. Yeah, yeah.
Thanks for that. And also, ayahuasca and psilocybin, know they are great treatments, to comment here, but I wonder, why does the research favor psilocybin over it must be over LSD. Ibogaine, sorry. Why is the research favoring psilocybin in your opinion?
Yeah, it's a few pragmatic reasons. You know, the trip's a good duration for a working day, 9 to 5, give or take. LSD is too long in that respect. You're going to be there into the evening. Ibogaine presents with a similar issue, but also some cardiac concerns around cardiac toxicity that requires a certain level of monitoring. And then ayahuasca, the combination has been a bit of a problem for research, having to, you know, mix compounds in a sense to get the effects. It's a bit of a shame that it's gone that way with ayahuasca. There's also that sense that it's there's a way of delivering it that honors its sort of indigenous heritage, and bringing it into a clinic where you just give the chemicals feels a little bit of a kind of appropriation. So, there's sensitivities around that as well.
Yeah, no, thanks for that. And there's a question here too about how is the setting, intentionality, and context being considered in administering psychedelics? That sort of goes to
Well,
what you were
I
just.
would say it's been considered for a long time, and it's really our model. The consideration is sort of thick in the field, and I'm a believer. I've written a paper on the essential importance of context, and so I share the assumption, but I'm also aware as a scientist that it hasn't been very well tested, at least in a controlled study. So when I said that's what I'm doing in San Francisco, that is what I'm doing. That's our flagship study, is testing that pretty, long held, even going back into, more ancient times, in the way psychedelics are given in a ritual, ceremonial way. That's an adherence and a acknowledgement of set and setting. Um, so it's a very strong assumption. Like I said, I share the assumption, but in the game we play today as researchers, or at least I play, we've got to test it. We've got to test it and see whether it's as robust as we assume it is. And if it is, then it'll inform practice going forwards. So it's really important. If we don't do it, people think that they can get away with just giving the drug. Or they start having these interesting thoughts about non-psychedelic psychedelics and so on. So it's really about, establishing the assumptions as being solid. Yeah.
No, thank you so much. And what are your thoughts on 5-MeO DMT? There's questions about that too.
So fascinating, novel pharmacology, novel phenomenology, huge experience. Why, how does it happen? Could it be therapeutically useful? All of those things, super fascinating. Yeah, I'd love to do more research with it, for sure.
Okay, thanks for that. Scott, is there any other question you want to quickly ask? Because then I want to thank Robin and
Perhaps I'll just grab one more. And I think maybe you've touched on some of this a little bit, but do you have any additional insights of the effects of patients who've been long-time users of SSRIs and how that might impact them if they then go from long-term use of SSRIs onto psilocybin as a treatment?
Yeah, I suspect it doesn't help, all those, let's say, years of daily drug ingestion. You'd think it's going to leave a pretty long impact on the functioning, maybe even the structure of the brain, such that it would take time to recalibrate, as if you'd never had that. So I know there are people who put a lot of emphasis on this issue, SSRI discontinuation syndrome. I don't know. I don't know the science super well in that respect, but I do think you can wash out. It's just washing out is difficult for people, and it requires very careful management, because the SSRI is probably being, in a sense, helping you more than you realize, or at least doing something that is, that when you take it away, the symptoms of anxiety and depression really come back with a vengeance. So in a sense, beware of withdrawal and discontinuation, and don't take that process lightly. However, if you're going to do it and you're doing it to have a psychedelic therapy, yeah, I guess the thinking would be, do it very carefully, do it properly, do it thoroughly, and don't do it alone, Yeah.
absolutely don't do it alone, folks.
Mm.
Just before I thank Robin, there's quite a few comments and questions about the different laws in different states of Australia where this can be done, etc., etc. So there is at the moment in New South Wales a review being done so that these treatments don't just have to take place in mental health hospitals. And we're hoping that the legislation will change in New South Wales very soon, but they're certainly available in a number of other states. And again, Scott can provide you with information about that, and Peter Hunt as well. So we have a lot of information. Scott, can you make a note? Maybe we'll put just a one-pager together on the state of these therapies in Australia on our download section. I think
Sure.
that'd be really good. And for those of you who are on this session, if you'd like to put something in the chat as a thank you to Robin, we will share it with him. And how fortunate are we to have Robin? There's so many questions I've lost count, and we haven't been able to ask you all of them. And I'm sorry for those that put in questions that we haven't been able to put to Robin, but we will definitely have him on again, perhaps next year. And we'd love to see him in Australia. Like I said before, Robin, you're a guest anytime you want to come round. And thank you just for your wisdom and your passion and the incredible groundbreaking work you're doing in this space. We're so lucky to have you in this world, and just keep at it, and come down under soon.
Yeah, I'd love to. I'd love to. So nice to see you. And Peter, thank you for having me on. It's been
No,
a
it's
pleasure.
a pleasure. Pleasure. Thanks, everyone. And we'll be sending you all a thank you note with links and this recording soon. Take care.